Are we ready to rock tonight? How we doing? I just pulled off a royal flush tonight. I'm feeling good about the start to my night here in Vegas. Um, and I am excited to have all my guests here tonight joining me for the course. And I tell you, it's time to get down to business. The truth is that when I start whenever I go to Las Vegas, I actually don't really gamble much. In fact, I enjoy being in Vegas a lot, but I don't spend a lot of time gambling, and it translates to how I do dentistry as well. Although, it is a fascinating thing how we have to manage the work that we do so that we can continue to grow as dentists, pushing ourselves to get better, but also have the wherewithal and the understanding of how to manage risk along the way. So, you know, there are things in Las Vegas that are just out of my control, so I usually avoid that kind of stuff. I wanted to start off by just mentioning, we're going to talk about immediate implants tonight, and I think that I can give you some things that'll really help you not only to have more confidence, but to have more control over the cases that you do. As we go tonight, there are some awesome opportunities for you to continue your learning coming up. And so the Little Implant Company has made some phenomenal offers to make it really easy for you to not only get what you need to do implants, but actually be able to learn how to use the implants in the best way possible. So I remember spending something like 25 to 30,000 for the very first implant system that I ever invested in, and then I spent probably another 10 to 15,000 on courses and learning, and it has been that at that level has proven to be some of the best money I've ever spent. The thing that's so cool now, though, and I think this is just a phenomenal time in dentistry, is that you can get started with implants for so much less, and you have better educational opportunities around that make life so much easier. And so I I tell you, I do not make a commission when you buy implants. I'm telling you, it's like the deal of the century, and these are phenomenal systems, phenomenal implants. So I'm so excited for y'all to have the opportunity to get involved with this. As we go, the real focus of tonight is not only on immediate implants, but it's how do we manage these cases. How do we manage from the point that a tooth has been removed to the time that we place the implant and get it finally restored. This case is actually showing you something that's been immediately loaded. And we're going to delve into all of that because I know that most of the time when you're learning dental implants, you really want to know how do you do all these different things and make it all work and make the outcomes predictable, and where you can uh, you know not only serve patients in an amazing way, but and get results that you're happy to photograph, but also allow yourself to sleep at night, which I think is a nice thing to be able to do. So as we get into this, I really want to help you understand the ways to manage all this to make it go great. So in the course of this webinar series, you learned initially from Dr. Tony Feck, and he's the best at teaching how to understand holistically what are we dealing with this patient, what is the situation, how do we manage, how do we striate our plans so that we know that before we ever even start a case, that we're entering into it with low risk. Then you jump from there into working with David Little the next week, where he's mainly teaching you how to do things with healed sites. And what's wonderful about that is that predictable implants with healed sites is really something that you'll find with this system is so doable in a general practice. And I have found that with the Little Implant Co. and the Mark Nevins implant and the Pamela Ray implants in particular, that the cases just go so smoothly. I wish I would have had this system years and years ago. I've been placing implants for over 17 years now, and thousands of implants in, many, many mistakes in, many opportunities to learn. I think I've figured out a few things that are worth sharing, and so I'm just happy to be able to do that. Once David taught you about placing implants in healed sites, then Dr. Pamela Ray taught you how to basically make every site into a healed site. And I think that's a phenomenal thing, because no matter what we do with immediate implants, whether we choose to do them or not, you got to realize that biology is a beautiful thing, and that most of the time you're just a few months away using Dr. Ray's techniques from being able to do exactly what Dr. Little taught you. So it's a wonderful thing in that regard. And then Dr. Gary M. taught you last week about how to systematically prepare for this, so that you can go through a defined process and make it literally like a checklist that a pilot would use to create beautiful outcomes every single time you do the cases. So the thing that makes immediate implants follow that fairly well is that there are a lot more pitfalls and a lot more curveballs that you can get thrown your way when it comes to immediate implants. And so before we go too far, I want to talk a little bit about just the psychology that you have to be prepared for, and understand as a dentist doing immediate implants. And the biggest thing is there's this wrestling match going on, is the way I see it. We're dentists, and if I ask you the question, what are patients actually buying from us when they're missing teeth or going to be missing teeth? A lot of dentists will answer that question and say, well, they're buying dental implants. And I say that is not actually what a patient is really buying. What they're buying is a solution to their problem, which is a new tooth. When they're missing a tooth, they want a new tooth. And so all they really care about is that they get that new tooth. They don't really care about how it happens. So we're trying to serve a patient by getting them a new tooth. And of course, everybody wants it as fast as possible, right? They want to be able to pull an app up on their phone that says, give me a new tooth, and boom, somehow it magically happens. That's what they would prefer. They don't want to have to do surgery. They don't want to have to do any of that. They don't even want to know that stuff has to happen for the most part. So we're trying to help them get a tooth as quickly as possible. And meanwhile, we've got biology that has, we have known things that are going to take a certain amount of time that we just can't get around. And so if we rush those things, every time we rush and push the envelope of what biology is giving us, we add to the risk. So we have to be able to manage that. We're trying to give a patient what they want and manage the risk at the same time, so that we ultimately end up where we have a great outcome for patients. And you have to realize that, this is if you get taught immediate implants, most anybody that ever teaches you this is going to say, well, place 30 implants first in healed sites before you ever even consider immediate implants. But the reality is that most of the time when a patient wants a tooth right away, that you're going to be torn in that wrestling match, trying to decide, how do I do this for them and get them what they want, while also managing the fact that maybe I don't have as much experience as I want to have. And so the paradox of experience is that, the more that you won, the more that the better you will do. But the problem is that the only way to really learn is to get experience. And if you don't have experience, you will find that you will make more mistakes. So guess when I had the most problems with dental implants was when I had the least experience. And so I think that it's really important that you be willing to, take on some of these cases and, go ahead and do some of the cases, But ideally, you want to start with healed sites. You want to start with cases that have higher predictability, less variables, less moving parts, things like that. On and like I said, if you use what Dr. Pamela Ray taught you, virtually all the sites can be ideal for you within 3 to 6 months. And, then you can get the experience with what Dr. David Little taught you doing, straightforward implant cases in healed sites as much as possible. That being said, I probably can guess that some of you will jump in and get going on all this. And so there's two sides of it. You have to know yourself. What I ultimately want to see everybody on this webinar do is to keep going, keep progressing as an implant doc. I want you to know what things will scare you away from doing this and try to avoid them. I want you to try to make things as predictable as you can, knowing your own comfort level and your own comfort zone, so that you are a doc that can keep making a progression towards being able to serve your patients and being able to give them more of what they want. And so regardless, no matter how confident you get in immediate implants, the thing that you have to realize also is that when it's, know when to hold them, know when to fold them, like the Gambler song said, that there are times where you just need to fold them and say, hey, can't do the implant today. We're going to have to put a graft in there and we're going to have to wait. Language matters so much in the way that you present that. And so if you're waiting to build up your experience level, that's okay. The key is to tell patients, hey, right now it's not ready for the dental implant, and we will be ready in 3 months. So let's set the stage to be prepared for that. I'm going to follow up. I'm going to check your healing. We're going to make sure that you're totally good to go. And in 3 months, we'll be able to do an implant and then get you started on building that tooth. And should be in 6, 7, 8 months, we'll be totally done with the whole thing. Now, the reason why I say language matters is because it's so critical that you don't hem-haw around about that. The less certain you see about that, that's the time when a patient is more likely to be, frustrated with you or lose confidence in you. So you want to speak confidently. You want to tell them exactly what they need to know, nothing more, nothing less, but be very succinct, very clear that this is what we need to do, this is in your best interest. And I always pave my way with words, and so before I ever even take a tooth out, I let people know, if possible, we'll place an implant for you today. If the bone's not ready for whatever reason, then we're going to wait. And so at the end of the appointment, I can either say, hey, great news, we took the tooth out, we were able to place the implant for you, everything went perfectly, I expect you're going to heal beautifully. And, I go through my thing, which also includes, if there's any trouble whatsoever, I want you to call me. We'll be calling to check on you. And then I'm also going to want to see you next week and check on you again. So I'm always telling them after the fact, but if I was not able to place the implant, I let them know, hey, the bone wasn't ready. I did place a graft. I set the stage so that you will be able to get an implant as soon as possible. And as soon as it's ready, we will take care of doing the implant as your healing allows us to do so. So the take-home message is that part of it is you've got to be willing to get in and learn and accept the fact that you may get some failure issues, okay? And it's never really the implant that fails. I mean, implants don't fail. It's the biology around them that typically gives way, and especially on immediate implants. A lot of times there's problems, and so we're going to get into that. The higher risk on immediate implants, the reality of that is that it's something that, the bone goes through a lot when a tooth is removed and an implant is placed, and the patient is going through this big healing process. You add more risk, and so you will get a higher incidence of non-integration events. It will happen, and the more you get experience, the more you can minimize that. And so what I'm hoping to do as we go through these next slides is to help you see ways to take from my experience and minimize your challenges right away. That will be my goal for you. So let's talk about the keys to success with the immediate procedures. And the real big keys are, that you have to be able to protect the bone in the site. You really need to have a 5-wall or 4-wall site with a floor. So doing that means you've got to have the skills to take implants out atraumatically. Okay, then, or take teeth out atraumatically, not implants, and then be able to assess that bone structure and then place the implant so that you've got excellent primary stability while keeping the implant, while keeping the bone intact in your procedure. Of course, before that, no active infection, and then we've got to cover it and protect it in a way that reduces the risk of exposure to some problem along the way. And then the way to reduce the risk as much as possible is to do no immediate loading of your immediate implants. So keep in mind that immediate implants mean we're taking a tooth out and the implant goes in. Immediate loading means we're putting the implant in and we're putting a tooth on it the same day. And I will tell you that I rarely immediate load. I have other ways that I go about, making sure that the patient has some sort of aesthetic enough solution to get them through the healing phase. But I really want to encourage, as you work initially to gain experience, let's just lower the risk as much as we possibly can. Now, the bonus at the end of this is that I'm going to show you there are some great things, great ways that you can do immediate loading or temporization of implants, no matter when you do it, whether you do it at day one or in the 3-month window or whatever. There are great ways to build provisionals and build restorations on implants right away. So don't worry, I'll show you some of that as long as we have some time. So let's talk about atraumatic extractions. The way that I want to see people really working to do this is just to be thinking as we're going to gently expand the bone. So we're not going to work and really force the bone hard with a lot of heavy turning with the periotome or the elevator. We're going to get the elevator in, we're going to work it down into the PDL and gradually put pressure on it in multiple directions to just gradually expand the bone. Okay, I love the use of things like physics forceps. I love the way that you can get a tooth to, and the bone to relax and let the tooth come out without having to be traumatic to the bone. Okay, when I get an anterior tooth, and if I can use a number 1 forcep, I want to seat the beaks of that number 1 forcep down into the cervical aspect of that tooth, and I want to make sure that I'm never using a buccal lingual motion to my number 1 forcep. I want to do what we call it an apical press, and then we're going to twist and twist the other ways. And then usually a lot of times if you apical pressure, twist, and then straight out, you'll find that with a number 1 forcep, if you've luxated a little bit and then you go do that, you can get an anterior tooth out wonderfully without ever creating problems for the bone. If the tooth is broken off, as you can see in the second picture, using an elevator to gently compress or expand that socket site and being very patient with this process, you can a lot of times get that tooth out. If you're having trouble with that, you can certainly section it and then take it out a half at a time. I rarely have to go to this, but every so often I do. So most of the time we can get in there and get the teeth out either in this shape with physics forceps, the number 1 forcep, and this, and then the elevator, and that will help us to preserve the bone site. With molars, I basically like to turn lower molars into premolars. So I section them right down through in between the roots and then take them out one at a time. I will start by elevating the whole tooth all at once, and then I'll go ahead and section it and then elevate one root at a time. And sometimes I'll even use the physics forceps on each one individually. Okay, you can get great socket sites. If we're going to put an immediate implant in here, then there's techniques for either using a surgical guide or you can work right down in through the interradicular bone. With upper molars, I section them usually in a Y-shaped fashion. So I go right through between the mesiobuccal and distobuccal roots, halfway across the tooth, and then I take it in a Y-shaped area, or section around that palatal root. And then I take them out one at a time, usually saving the palatal root for last. And I, just gently work those elevators down in as deep as I can to luxate each root individually. Once you do that, you'll find that you can keep bone very well intact. And a quick side note is that I rarely do place immediate implants on upper molars. It's got to be a lot of bone in between the roots before I do that, because usually you end up with some implants that are just not in spots that I like. So upper molars typically are 3 months and come back in and place an implant exactly where I want it. I love periotomes for getting down into these ligament spaces as deep as possible and separating between the root and the bone. I think that periotomes are wonderful for that. So again, using techniques like this, the key is patience. The key is to work and expand and gently get down in there to create separation between the tooth and the bone space. So once you do that, you'll find that the teeth really will acquiesce and come out pretty darn well. And once you have done that, keeping the bone intact becomes, for all intents and purposes, a non-issue on teeth that don't have some form of ankylosis or that sort of thing. Okay, so then how do we know then, once we've taken the tooth out, that we actually do in fact have intact walls and a floor of bone? And so there's really only two ways. One is to reflect the tissue and look at the bone, or two is to get used to using a perio probe in a way that helps you determine that your bone walls are actually intact. And so a lot of times I really try to never flap these cases unless I find that there is in fact a defect. So I walk my perio probe down and along the walls. Now what I also do is I'll put my finger out here on the buccal plate, and I'll walk that perio probe, or I'll go all the way to the depth of the socket, and then I don't poke with my perio probe. I actually just set it against the buccal wall. I set it against the mesial, distal, and lingual walls, and I just gently walk up that wall, just with gentle pressure. And if there's a perforation, you'll be able to feel it with your finger. You'll certainly be able to, if you let the tip of the perio probe, if you just hold a light touch on that perio probe with your fingers and you just walk it up those walls, you'll find that you can translate the tactile sense of that perio probe right into your fingertips, as if it is your fingers down in there feeling around and seeing what's going on. And if you do that, you'll find that if there are any fenestrations or dehiscences, you'll be able to tell that they're there. If you have your finger out there on the buccal wall, you'll find that you actually will be able to tell by just purely feeling the perio probe with your finger. So if you have to flap the tissue, now this is a situation where I really want you to go back and look at what Dr. Ray taught last week, because cases like this are going to require a more sophisticated level of grafting. When you got this level of dehiscence and it's exposed like that, you're going to need membranes, you're going to need a great quality bone graft. So I'm typically using something like a cross-linked collagen, a corticocancellous mix of bone, something to that effect. And we're going to suture this in a way that gets and cover this up so that we get great healing. Primary closure is my preferred way on that, and really needs to be the way to do it when you're building a new wall. If you have to build a wall of bone like this, I also allow more time for healing. If I'm grafting a site that has all the walls intact, most of the time 3 months is a slam dunk to place an implant. If the walls aren't intact and you've got a wall that you're going to really be relying on, I a lot of times am waiting 4 or 5 months on that. And so just to keep that in mind, the way that we would plan these cases so that we're not only successful now, but successful in the future. Okay, so you have to be able to flap, or you have to be able to see it with your perio probe. I use the perio probe all the time. In fact, I never flap these cases until I have found a defect, and then I may flap in some way to expose and treat the site appropriately. All right, primary stability is the next key for success. So we've covered getting the bone or getting the tooth out and keeping the bone intact, and then assessing that the bone is in fact, um, ready for the implant. Now we've got to get the implant in and know that it's going in there with great stability. Okay, so how do we do that? Well, let's look at it. Let's look at the nature of how teeth sit in bone. So a lot of times, what you'll find is the most common teeth that patients come in with like a crown in their hand are, it seems to me to be lateral incisors and upper and lower premolars. So they've had a tooth that's had an endo, it's had a crown, whatever has happened, and now they come in with the crown in their hand, and we've got to decide, is it restorable, is it not? Well, in this case, the tooth's not restorable. And, if you look at this on the cross section of the CBCT, you can see the nature of a lot of upper teeth. If you look, the way this root sits in the bone, this is all bone to the lingual and apical of that natural tooth. But if you look here, there's just a thin plate of buccal bone. And a lot of times you can't even see the differentiation between the tooth and the buccal bone. And so when you see this, you'll realize that, one, you've got to very atraumatically get this tooth out so you preserve that thin shell of bone. But two, know that if you're going to really try to get primary stability on this, that you've got to somehow drill into this bone and get your implant anchored into this fresh bone, apical and lingual to where the tooth is. So most of the time on upper teeth, all the bone you need is on the lingual and apical aspects of it, or palatal aspects of where the original root is. So I most of the time do this freehand, but you can learn to drill into this wall without letting your drill slide all the way down to the apex and out the buccal plate. That would be bad. Okay, we want to drill right into this palatal bone and anchor our implant in there. And if you see, this is going to translate an implant beautifully to where it comes out right through the cingulum of where the original tooth was. That's an awesome outcome. Now, the other opportunity, if you're less confident in that as a technique, then is to use a pilot drill guide or some other type of fully guided surgery process to get your initial implant placement as perfect as you possibly can. So either one of those are options. Like I said, a lot of the reasons why I go freehand on this, one, I feel confident that I can do it. Two is because, again, a patient came to me with a tooth in their hand and they want to get a tooth back. So I usually don't wait to get a guide made. I go ahead and start the process of getting the tooth out, getting the implant in for them right away. You have to know yourself and know, if this doesn't go well, am I going to stick around? Am I going to still be an implant doctor? Or is it going to shake me up too bad to have that happen? If it goes great, of course, it'll be a wonderful thing. But you've got to know yourself and know what you're willing to get yourself into. Okay. Another case, here's something to really, I think, is interesting to learn. But if you look at lower anterior implants, a lot of the times, if you look at where those lower anterior teeth sit in the bone, they're very coronally positioned in the bone, and a lot of times very facially positioned as well. And so by the time you take those out, there's the bone right around the roots of these teeth, especially when they're periodontally involved in any way. The bone right around the roots of those teeth is not very robust at all. But then if you look at all this bone that's apical to that, all this bone that's apical to those teeth, you'll realize that if you take these teeth out and you alveoplasty this bone and then place your implants deeper, that a lot of times you got some of the best bone you'll ever work with. And like Dr. Little and Dr. M both showed you guys, this is D1 bone, very, very dense bone. So as long as you use lots of water, be patient with your drilling process, in this bone, you're going to have extremely high success rates. But it's very dense bone, so you've got to manage your drilling protocols. But in this case, if you go in and take these teeth out and you alveoplasty that pretty well down, you're going to find that you're almost like treating healed sites, because you're not dealing with sockets near so much. Now, I may not take away the entire part of the bone that had the teeth in it, but I'm sure going to get down to where I've got more robust buccal and lingual walls, keeping in mind that we want to try to always have, 2 millimeters of bone all the way around our implants. So let that be kind of your North Star as what your criteria for success will be. So place your implants deep enough so that you're going to have good bone and take advantage of this robust, dense, strong bone that's down here. Okay. Another instance is let's look at this where we're particularly looking at this tooth that's a failing tooth. And when you see this slice right here, what do you think is going on just apical to that implant? Well, if you look, the mental foramen is right down there. So how much bone do I have to work with below that? Can I actually drill past the socket site, or do I have to work within the socket site, or should I graft and wait? Those are the questions that you're going to have to answer. And a lot of times, in cases like this, we either drill just a little bit in past the socket site, or we will use the socket site itself and just maximize that while placing an implant that will work great in that case. So I'm going to show you a little bit more about how to do that. Okay, let's look at one more CT scan here where we're really looking at how we would plan this. So in this case, you can see the tooth is sitting more lingual in the bone. It's not sitting near so much out here on this buccal plate. So we've got a good thick buccal plate right here. That in one case, that's going to mean the tooth's going to be a little bit harder to get out. On another way of looking at it though is that it's going to be, the bone is likely going to stay intact better. So that's a really wonderful thing. But look at all this bone that's apical and even lingual to where that tooth is. Most of it's really directly apical. This is a great immediate implant case for you if you're starting out trying to figure out how to do immediate implants. You take this tooth out, you drill right through where the apex was, go about, in this situation, you probably have 6 millimeters or so of additional bone beyond that. So you can place an implant well beyond the apex of the original root. In that case, you're going to have an excellent situation of primary stability. And again, you can freehand this, or if you're not as confident in that, get a surgical guide made so that you get your drilling done right where you're at. Now, I'm all about finding what the natural anatomy is showing me. And in this case, if the natural anatomy has literally a point pointing me where I want to go, I'll use it and I'll go with it. And I won't worry about a surgical guide on those kinds of cases. Okay. Let's talk about upper premolars. 2 rooted premolars. You can also envision this as if it didn't have this interradicular bone here. When you look at where the tooth is or was and where it is going to be, you look at how, we know there's probably going to be a very thin buccal plate out here. We know these teeth sit very buccally positioned in the bone if you look at a CBCT of them. So your safest bet is to plan for your implant to go more in the lingual aspect of that socket site. So if you picture it in here, we're going to place our implant literally in this lingual bone or right through the interradicular bone and to the lingual of that, to place the implant right in this space so that when we restore it, we'll be able to, or when we finish that, we'll be able to graft this area out here, thicken up the buccal plate so that we have a more robust buccal plate, getting us at least 2 millimeters of bone around that. And then we can build a tooth that's going to be ideally positioned for the future. Okay, so here's an example of an immediate implant where we've got a tooth that's beyond repair. Okay, you can see that it's decayed even below the bone, but it's got a fairly short root, so we know we've got a mile of bone north of that tooth. Okay, so when we take that out, we know in this case we're not going to just use the socket site. We're going to want to anchor into some of this great new bone up here and treat it like a fresh osteotomy up there. Okay, but again, we're going to want to place this implant in this place where it really sits in the cingulum of where the original tooth was. That's more optimal placement. And then we're going to graft out on the buccal of that. And we're going to create a thicker buccal plate out there for our implant to sit in. So when, again, referring back to Dr. Ray from last week or 2 weeks ago, is a great way to go back and review your techniques on this. I will go into it some, but I love leaving space here on the buckle of an implant so that we can graft it. If you place your implants in where they're pressing on the buckle plate, or even worse, fracturing the buckle plate, fully occluding the site, things like that, I think it actually adds risk to your case, because most of the time those buckle plates are just not very thick. So place your implant where you actually leave a little space, and then you can graft it and end up with a wonderful outcome going that route. The surgical guide can certainly help you get optimal positioning if you don't feel comfortable going freehand on this. I love, after you've done your initial osteotomy, place a parallel pin in there and just look. Does it sit center between the teeth? Is it in, not only in the occlusal plane, but in the buccal lingual plane? It's sitting where it ought to be, plus mesial distal. Are all three planes really where you want them to be? And if so, you're going to be in an optimal situation to get not only a great restorative outcome, but structurally, you know that the bone is made to handle that. So getting an implant in, apical to where the tooth originally was, is going to absolutely up your chances of having a wonderful high success rate in your career. Okay. So if you go back and you look, all right, I just showed you a couple cases where we're drilling apically past the original tooth, anchoring into that bone. If you're ever even going to think about doing immediate loading on these cases, you have to be able to do that. Okay, you have to drill past where the original tooth was. But let's look at a case where anatomically on the lower, whether it's the mental foramen or the IA nerve, there are times when you just can't drill past your original site. So then what do you do? Well, if you look closely at this case, we've got good thick bone on both buccal and lingual. We can't really go apical too much, if any at all. So we want to put an implant in that's going to have good stability without breaking or fracturing that bone. So it's got to be not too big, not too small, just right for the site. So you pick an implant based on the size of the site. The only way to know for sure what the size of the site is to measure it. And so a lot of times we're going to measure not only the full depth of the site, we're going to measure the width of the site. And a lot of times I'm going to actually use the original tooth root and measure the size of that tooth root from buccal to lingual, from mesial to distal, and of course the length of it, and have a really good feel for what the total 3D measurements are of that site. Now, anytime we're doing an immediate implant, we want to get that implant at least 1 millimeter to 2 millimeters subcrestal. In the anteriors, I like them deeper. In the posteriors, I like them at least 1 millimeter subcrestal. In the anteriors, I like at least 2. Okay, so we want to get the implant in not only below the crest. Why? The reason why is because we're going to see some remodeling once you take a tooth out. But once you take that tooth out, you know that some remodeling is going to happen. So we account for it ahead of the game by getting our implants subcrestal. Really, the cardinal sin is to get your implants supracrestal, where you could end up with threads exposed. That's when peri-implant conditions end up becoming very, you end up susceptible to peri-implant mucositis, peri-implantitis, things like that. So getting our threads below the bone is mission critical. Well, again, if we're working in a site that we can't drill past, and we don't really want to create any risk of fracture down here, we're actually going to stay short of the apex of that site as well. So if we have a 15 millimeter total depth and we're going to stay 2 millimeters short of the apex, and we're going to go 2 millimeters subcrestal, now we know that we have the ability to place an implant that is much shorter than the actual socket length. Okay, so in my mind, I'm thinking, something that's in the 10 or 11 range in a case like this. Okay, now let's look at the width. If we know that we can place a 10 millimeter implant in that site, and we've got 4 millimeters of width, Now you've got to be thinking something at least 4.2 millimeters or 5 millimeters in diameter. Those are two of the diameters that would potentially work really well in this situation. The thing is that if this mesial distal dimension is 4 millimeters, this dimension is usually somewhere in the 6 to 7 millimeter range. So a lot of times a 5 by 10 implant is going to work beautifully in that. And the 5 is going to anchor into these walls beautifully on the mesial and distal without fracturing anything, and you can still leave space around your buccal plate. I love to place these implants more lingual, okay? So I like to have the implant sit more like in this space right here, and then leave a little space out here to graft, okay? So a 5 millimeter implant is a really good size. Most of my anteriors, like 8 and 9 type teeth, certainly canines, are going to be 5s or 4.2s. In the lateral incisors, a lot of times they're going to be 4.2s and sometimes 3.85s. Okay, so in the premolars, most of the time, especially if I can drill past the tooth, I'm going something like a 4.2 by 13. That's a pretty common size that I'm going to use back there. So just keep in mind that that's the kind of, you want to be able to get great stability by anchoring into at least 2 walls. But if you think about it, if you've got an implant sitting in here, let's say it's got decent contact with the lingual bone, it's fairly snugly placed against the mesial and distal bone, but you've got space out here. That's a tooth that, to me, I'm a little less inclined to consider immediate loading, because there is room for error in there. If you immediate load that, they bite on it. Even if you tell them not to do it, you know, there's a risk that they could jostle that implant loose. Now, if you've gone past the apex and you've drilled into bone deeper than that, you're going to have better stability. But in a case like this, where you're using the socket there, don't even think about immediate loading. Don't even consider it. It's just adding too much risk to the case. So there you go. There's from the tooth to the implant. You can see we stayed inside of the socket that was there, okay? And, you know, placed a nice healing cap with a platform switch. So in this case, it's a 4.2 millimeter implant, and we were able to use a 13, okay? So in that case, 4.2 by 13, without even drilling past the apex of that. You can't do that in all teeth, but in a you know, one of these you can. And then placing it subcrestal, okay? And then, you know, in this case, able to put a healing cap on it and suture around that to where the tooth is or the implant is still out of harm's way, but we'll have a really nice permucosal extension through the tissue, which will give us a nice tissue collar that will allow, you know, for very rapid, transition into restorative phase when the time is right. Usually not even a second stage surgery needed at all to uncover an implant like that. So it's a great way to go, and certainly something that you could do where you eliminate the risk of, you know, dealing of a mental foramen issue and, you know, having paresthesia or worse. So that's a technique that certainly works really well. Diagrammatically, you know, getting this tooth out atraumatically, measuring it from all dimensions, placing your implant in there, staying short of the apex, okay? You can also just put a cover screw on it. There's a cover screw inside the lid of every one of those implant vials. You can just put it in there, cover it up, suture the tissue over it, graft the gaps, and leave it, and that minimizes your risk to the lowest possible point that it can be. So doing that, to me, is, again, know yourself. If you feel like the lowest risk possible is the way to go for you because you might be inclined to get gun shy about placing implants at all, then I would say stay on the lowest risk point. The only reason why I like to place a healing cap that comes partway through the tissue, I still leave it below the tissue, is just to start developing that permucosal tissue aspect so that we start developing our emergence profile from the beginning. And by the time it heals, like I said, a lot of times the uncovering process is completely simple. You maybe a little bit of anesthesia, you go in and you basically turn that healing cap out and place whatever, impression coping or prosthetic you're going to use, and your tissue's pretty well ready to go for restorative without any second surgeries. So that's a nice way to go. Lowest risk, cover screw. Second lowest risk, healing cap that's below the tissue where their tongue and anything occlusally can't touch it. If they're wearing a partial over that, there can't be anything touching it. So I like to leave that totally alone, especially if we aren't drilled past our socket. Okay, so here's a situation where on the lower I mentioned the IA canal and the mental foramen. On the upper, we're more dealing with things like the sinuses. And so if we want to stay shy of the sinuses, same thing. You take that tooth out, measure it from all directions, okay, and then place an implant that again doesn't over compress the bone in the buccal or lingual directions. If I ever had problems with immediate implants trying to do them with this sort of a technique in the past, it was when I placed the implant and I didn't fully have control over it and something put too much pressure on that buccal plate. So I can honestly say with healed sites with the Nevins implant, placing them for the better part of a year and doing hundreds, I don't know if I'm up to 1,000 of them yet or not, but lots of them. And I've had 0 failures of integration on healed sites. And I've had 1 non-integration event on an immediate site. And truth be told, it was a smoker, probably a diabetic too, that they just haven't been to the doctor. You know how that goes. So I want you to know that these are predictable techniques if you follow the process very well. But if you're going to have problems, it's going to be on these cases where the bone is just going through a lot and things just don't seem to integrate well. Doesn't mean that you're a bad clinician. It just means that you're going to get a setback. And when it happens, if you add in my opportunities for redos, so if an implant doesn't integrate, I graft the area, I come back in 3 months or however much time I need, and I place the implant. So in actuality, I have 100% success rate on all implants because I learned and I did a redo. And no, whenever I may charge the patient for that grafting that I did, or if I have to do membranes, things like that, I may charge them for that, but I actually don't charge them to redo the implant. And I know when they smoke and they got diabetes, I've even warned them that they're high risk and blah, 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 all that. I tell them there's a chance that problems can occur, and I still don't charge them. To me, it's just me paying the tuition and learning. It's me having the opportunity to get better, and it's also me just not worrying about it. I've just chosen to fix problems rather than fight patients over who was right, who was wrong, whatever else. I just fix it, move on, call it good, and figure that it's all about building goodwill. So that's my way of going that. So again, in these cases, the biggest cardinal sin is to overstress the lingual or the buccal bone. And if in doubt, place these implants more lingual. Don't let them press on the buccal bone, or that's where you might fracture that bone and get a failure. I have had, years ago when I first did some immediate implants, I thought, man, if I don't flap it and I get a little fracture to the bone, I might be able to get away with that. Nope, doesn't work. Take it from the brain damage that I've already gone through. That don't try it. Keep your implants more lingual. Learn from my mistakes and just stick in there where you've got rock solid bone, and then grafted it, and then reflect this tissue just enough to where you can get closure around your healing cap, get it covered up well, use the techniques that Dr. Ray taught you, and you'll be in great shape to have a beautiful outcome. Okay, so the next thing is no active infection. And the basic rule of thumb is if it is actively infected and they're in your office today and they want an implant today, the answer is no, it's not ready. Okay, so there's a couple ways to deal with that. One, if you have a site that you're confident the body has walled off and you've got you've got granulation tissue in there and you just need to get it out, the key is to use multiple curettes of different sizes. So I've got some curettes that are in my surgical kits that are kind of those go-to standard sizes, but then I also keep some really small ones that are closer to like hygiene type curettes that I can get clear to the apex of these areas. And so when you curette a site, if it feels squishy, soft at all, you've still got tissue in there. And if you keep your finger on the buccal plate, even on the lingual, and you're curetting, and you can't feel the tip of that instrument, you know the bone's intact. So curette away, be aggressive, get that crud out of there. So I curette. My assistant knows this. A lot of times she's just spraying cold water into the site or waiting until I'm done, and then she'll irrigate for 10, 15 seconds with cold water. Then I'll go back, curette a whole bunch more, re-irrigate, curette some more, and literally when I think I'm done and I have the site clean, I go ahead and have her irrigate, and then I curette even one more time after that. You can't leave the granulation tissue in these sites, and certainly if there's active infection, that's a real problem. But if there's any of that stuff is in there, you're going to have problems with your implant. So lower your risk by getting them cleaned up. Of course, the body will help clean it up if you give the body time to do it and you get the tooth out. So that's another way. If you're just not sure, hey, know when to fold them, know when to hold them, wait, let it heal, graft it, whatever you need to do, and then come back and place your implant in a healed site. If you're in there curetting and it feels squishy at all, it's either a perforation or it is granulation tissue. So what you have to discern is that you keep working, and if there's squishiness at all and you're not on this smooth, clean bone where everything feels hard and it feels smooth in there and it's not squishy at all, you're not done yet. Keep curetting. And when I've taught live courses and people have seen me do this, they're like, holy smokes, you spent a lot of time doing that. Yes, that's absolutely right, I did. And they're always amazed. I'll spend time because I can feel it. And then finally, when a big wad of this kind of stuff comes out, they go, holy smokes, that was in there? And yep, that was the case. It was in there, and you got to get it out. Okay. So the second thing though is if there's active infection, okay, we can't do it today. Okay. If we've got a tooth that's got, so we're going to abort mission if there is active infection in there, or we're going to use preoperative antibiotics. So if I'm confident that it's a really aggressive infection or a chronic infected area that's been like that, I'm going to go ahead and be pretty aggressive with Augmentin. I'll go 500 milligrams for 10 days, and I actually start it 5 days before the procedure. So I want the Augmentin in there, killing that infection, get it cleared in every way we possibly can. Then we take the tooth out, we curette and clean the site like crazy. I don't put antibiotics into the site. I don't use chlorhexidine or anything like that in the site. I just cold water and curettes, and then I let them stay on the antibiotics for 5 more days after the procedure. Okay. If I'm confident that it's actually, possibly just like a periapical scar from a previous endo or something that doesn't have the signs of active infection at all, then I'm going to go ahead and just put them on a routine protocol where they're going to start 2 days before the procedure on amoxicillin or Augmentin, 875 BID, so 2 times a day, and they'll start 2 days prior, and then it'll just carry through 5 days after. If I place an implant the day that they come in to see me, and it's a healed site, and I'm placing an implant, I go 875 milligrams of amoxicillin for 5 days, okay, BID. So that's the difference. I just want, if there's any risk at all, I lower it where there might have been an infection in there at all, any bacteria possible at all. I'm going to go ahead and start ahead of the procedure and do the treatment. So it's one of the few times where I'm delaying patients. I'm saying, hey, we can't do this today. I want to do it in 5 days. Okay, and they'll come back. They'll be okay. And a lot of times we use that time to make them a flipper or make them an Essex retainer with a tooth in it, whatever it is that we may do, again, because most of the time we're not going to immediate load these cases anyway. So we go ahead and get them a temporary something made So then they're on the antibiotics, they come in, we take the tooth out, we clean it, we place the implant, and we put their temporary whatever in their mouth, and they walk out with something in there. So that's the way that we sort of structure that strategically. Okay, the second part, again, covering the implant and grafting, a lot of this is the same as what you would have learned from Dr. Ray. But again, we want to, when we place our implants in these sites, placing them more lingual is really mission critical in the anterior. Leaving a millimeter or two of gap in here is great, because remember, very thin bone most of the time. Grafting this and then closing it is a wonderful thing to do. So we'll graft it, we'll place that bone in there, trying to not necessarily touch the facial aspect of our implant with the instrument, but just pressing that bone down into place. I use very small instruments to make sure that I get the bone placed as far apically as I can. Then I work my way up to bigger instruments. We use things like gauze or cotton rolls to blot out the excess moisture while we pack that bone down into place. Okay, and then if you need a membrane, you use it. If the bone's intact, which is optimal, you don't need a membrane. So we're just going to cover the area. We place our bone graft, and then we're going to suture to get tissue snug around that healing cap. So here you can see this is a 3 millimeter healing cap, and the bone or the implant is placed very apical to the bone structure. So we've got at least 2 millimeters of bone that we're subcrestal to. This may be a 2 millimeter healing cap. Again, a small platform switch there. The implant's placed and anchored into bone way apical to where the tooth was. And then we're going to suture the tissue so that it really is very firm around that healing cap. And that's going to hold all that bone in and actually give us a really wonderful outcome. Now, on this case, I try to reflect the tissue just enough so that this can be as tension-free as possible. But that tissue will stretch quite a bit. So just know that as you suture back and forth across there, you can pull on the tissue and get it to move and be pretty snug around that. But if you release it just a little bit, I try to stay right at or above the mucogingival junction. Just release that tissue enough so that it can stretch. If you really want to learn to get tissue to go a long way, you need to learn how to do a further reflection of the flap, periosteal releasing incisions, things like that. And you can learn to get tissue to migrate a long ways to get primary closure. That's a big deal as you get more and more advanced in your grafting techniques. People like Dr. Ray can really teach you those things. They're wonderful, wonderful techniques to learn as you evolve and grow as a clinician. I use base bone. I don't usually use putty material. I'm a lot like Dr. Ray in that I use the particulate graft. Most of the time I hydrate it for 5 minutes at least. So most of the time when we're doing immediate cases, my assistants know to at least get a 0.25 or a 0.5 vial of bone ready, depending on the size of the tooth that we're replacing. And they go ahead and usually just use sterile saline. And then if we have a socket that's full of blood after we've got done curetting it or whatever, we might use a little bit of that blood and put it into this dish as well. And then we dry it out. We just wick up the moisture with a 2x2 or a cotton roll and let that moisture soak out of there. And then we have a bone graft that's perfectly hydrated so that it stays on your instrument just like this. And it just works really well. You can obviously go more advanced and add things like the GYM21 growth factors. You can also do like the advanced PRF that Dr. Ray talked about. You can get into things like that, but initially you'll find that most of your cases you can do really well hydrating with sterile saline and just using the blood from the patient's mouth and again, most of the time just sterile saline, and you can graft these sites beautifully. And you can still get great outcomes with that. Okay, so if we're grafting, into any site where, we've got the site clean, we use the particulate bone graft, we use instruments like, like a bone carrier or even the end of a molt or a Woodson to just carry the bone to the side. My assistants will carry it over, then I usually pack it in with, a curette or some instrument that fits the site perfectly. We want to see that bone graft get perfused with bone. I like to release this tissue just a little bit, cover it with a plug, and suture the tissue so that it covers most of the way over that. If I've placed an implant in this area, the more I want to try to get the tissue closed in around the implant as much as possible, if not even primary closure. So that requires a little more reflection and release to get this tissue up here. Okay, so there I'm showing you part of the technique that Dr. Ray showed, which is using like the cut down collar plug just as a disc that you can place in that area and either use periacral glue or you can suture it into place. Okay, so the short answer as the last key to success is just to not immediate load. Use in the anteriors, use flippers, Essex retainers, or something that's bonded to an adjacent tooth, a Maryland bridge, things like that. Those are great opportunities for you, okay? But just know that in the system, there are ways to immediate load. Before we finish today, though, I want to make sure that you know that in this summer webinar series, there's been a lot of method to this madness in the way that it's built on the knowledge week to week. And the last week is next week with Dr. David Little, and his teaching that will be on the single tooth implant treatment will be really awesome for you to see not only single tooth placement and treatment, but the digital workflow, and really dig into all of that, because that'll take you to the next level of how to understand where you may be able to go as a clinician. The other thing is that as a gift for being here tonight, you're going to get a copy of the surgical manuals emailed to you. Everybody that's on this webinar tonight, it looks like we've had several hundred people here tonight, which is awesome. I commend you all for spending your evening doing this. So those manuals are great. I highly encourage you to get where if you need them, put them in, look at them before every case. Bring them to a place where you can see them in your operatory if you need them. Don't be shy about things like that. Patients are cool. Like they get that, people need to follow a process and a protocol. And so just make it so that it's a normal part of your routine. Don't be shy about that. The last thing that I want to mention again is, I just can't even understate how much I feel like this is like the no-brainer of the century. Again, I don't get paid for you to buy implants. This is such a wonderful thing. I really do speak from the heart when I say I love the Mark Nevins and the Pamela Ray implants. I do think they are the best implants I've ever placed in my career, which is, counting dental schools, getting close to 20 years of experience with this type of thing, 17 years in my own private practice, and doing, the last half of my career, the vast majority of the work that I do is implant and surgically related work. And, it is, I've spent a lot more on implant systems that I like a lot less, and they sit on my shelves while I go ahead and place hundreds and hundreds of Mark Nevins implants and Pamela Ray implants. So I love this system. I speak from the heart when I tell you that. And so, if you get going with it, grab onto this offer. It doesn't get better than that. I can't even imagine. And then take the courses for $1. Holy smokes, it amazes me. So this is a company that's committed to not only getting you a top-notch product, but getting you the education that goes with it so that you can really go do these cases and be successful as an implant doctor. So I think that's amazing. Call Jessica, text her, get in touch with her and get started on that if it's something that you're thinking about doing. Then jump in and take those courses and look for the next levels of learning that are going to be coming. You're going to see some amazing new things that are going to allow you to learn, not only teaching your team at your office, but up your game and your skill set on your own time without even having to travel in some cases. So keep an eye out for that. I'm going to jump on some questions rather than going into more about immediate loading, I want to make sure that I've answered any questions before I go. So feel free to fire my way if you have questions that you'd like to ask. I'm just going to look through here real quick. So the first question came in much early in the presentation, was asking whether I take a CBCT before tooth extraction. I take a CBCT on all my cases. That being said, I've been doing this since way before CBCTs were even possible in most of these cases. And so, if you follow the process, you'll find CBCTs make it so much more easy to plan and predict, yet you can look and really know where you're going without them in most cases. But so the answer to your question is yes, I use them all the time. And I do wholeheartedly believe they will up your confidence and they'll up your ability to really plan a case well. So highly recommended. But I do have a long track record of saying that it isn't that I had to have it before that, it just makes me better now. Okay, next question is, do I always section molars? And I would say always is probably pushing it a little bit, because I don't always, but I would say 95% of the time I do section molars. So lowers, I just make that one cut. Uppers, I go ahead and make that Y-shaped section, and that's it. All the other teeth I don't section hardly ever. So I hope that answers that question well. My favorite brand of forceps, I actually have been, I really do like the physics forceps a lot for atraumatic extractions. I do also use a lot of the, I've been really enjoying a lot of the surgical instruments through Berman Instruments. I feel like they're really nice instruments with a great value. So don't hesitate to check out that site. But I don't really get into a lot of other gizmos. I use a lot of I love the #1 forcep in the anterior. I love the #13 forcep in the lower anterior. I use a lot of universal forceps as well. So that, is going to, I think that'll get the vast majority of your works, vast majority of your work, taken care of. Okay, another question is, when you do an immediate implant, do you use a wider implant than you normally would so it grabs into the walls from the extraction? I may have already answered that. I do use a slightly wider implant than the walls, at least to try to grab into 2 of the walls, which usually, in the case that I showed, are the buccal and lingual walls. So I don't want to over compress those walls, but I want that implant to really lock in there solid. So if I've got a 4mm wide area, I'll probably place a 4.2 or a 5 there for sure. Okay, let's go to the next question. So do I normally place the Mark Nevins implants by hand or using a motor? And the answer is, most of the time now I place them. I was always place implants by hand, implant doc, for many years. And now I love using the motor with the Mark Nevins. So I use the motor almost all the time with the Nevins, but I actually place some by hand as well, and you can do both. And that was another part of the question. Let's keep going here. So one of the questions was, if using a healing cap with immediate implants, some surgeons consider that to be early loading or immediate loading because the tongue can get in there and push on the healing cap. So what I like to do is place a healing cap that so if I've got, say, 3-4 millimeters of tissue, and I've placed my implant 1 or 2 millimeters subcrestal, I can put a 3mm healing cap on that and still almost get primary closure over the top of it. So what I actually have is a situation where the healing cap sits down below the tissue. And so I almost never place longer than a 3mm in that sort of case. I want it to be, if I have any doubts about the stability, then I place a lower healing cap or a cover screw. But I agree with you in that if their tongue can get in there and push on it, that's bad. So you want to place it below the tissue where their tongue can't really do that. And if you do it that way, you're going to find that it will be protected and you won't have problems. That being said, if your tolerance for risk, is even lower than cover screw, no problem, and you'll be able to, get back in there and uncover it later. So seeing some awesome compliments. Thank you guys for the compliments. I really appreciate that. And I appreciate you guys being here tonight. One of the questions was what makes these the best implants for me to use? And it's a multifactorial answer. I love these implants because not only do I get amazing stability with them, not only can I use them in both aesthetic areas as well as highly functional areas, and to me they allow me to reach more patients because I can use them where in many cases where in the past I maybe would have had to have grafted instead of using a shorter, wider implant, or maybe I can reduce the extra procedures. I can also just reduce the cost. When my implants are costing around $100, $120, whatever the case may be, and in this situation you're buying your implants for something like 90 some dollars. I'm not sure of the math on that, but what you'll find is that you can make your fees still be very profitable to your practice and reach more patients. To me, it's making it so not only does our implant help us accommodate more clinical situations, but it also helps us accommodate more financial situations, which is the reality of our world. Most of us don't practice in a place where patients just have an open checkbook and just can buy all the stuff they want. If you can be more flexible with your fees and still make your practice extremely profitable, you'll find that you're serving more people and that your practice is more profitable than it's ever been. And that's something that I think I've very much proven. I practice in a very middle class town of about 50,000 people is where my main practice is. And I was already doing a lot of dentistry, personally, doing 7 figures a year practice, and I was able to essentially double that by changing a few things in the way that I structured my implant programs for patients. So, and that was just a paradigm shift on my part. My skills got better, but my mindset changed towards how I accommodated people, and more people were able to say, yes, it works. One of the, let's look here. One of the questions was, do I use the Austell instrument to determine stability or the torque wrench? My preference is to develop the feel and the use of the torque wrench. I don't do a lot of early immediate type of loading, and there's been enough studies to show that the Austell, while it gives us data that helps us, it doesn't necessarily always give you the exact answer. And so what I have found is, you're better to continue to work and develop your hand, your feel for it, and more than anything, respect the biology. If a patient's totally healthy, you can place an implant in a healed site, goes in excellently stable, 3 months, restore it, and you will literally have no problems. If you have somebody that the same exact situation, but they smoke or they have diabetes, for each one of those conditions, I add a month. So I might wait a month longer for the diabetes and an additional month for the smoking, things like that. I just stack the deck in my favor. So to me, it's following a protocol and then knowing that biology really does work at its own pace. And if you respect that, you'll get highly predictable results, and you don't need yet another expensive gizmo in your practice. That's just my opinion, and it's worth whatever you pay for it. So I have read plenty of studies that show that the Ostel thing, while it's marketed really beautifully, it isn't 100% tried and true. And so there you have it. So what happens to the sensitivity post-op when you drill the implant past the original apex? Absolutely nothing. In fact, that bone, while the bone has nerves that run through it, it's not, the bone is not directly innervated. The pain that they're going to have from this procedure, and I always talk to patients about this, say, look, most of the time when I place implants, we try to do it with, minimally invasive techniques where patients literally have no post-op pain. But you had a tooth taken out today, and there's going to be some soreness. When you put that physics forceps and you press and you work on their buccal plate, they're going to be sore up there. That's just the reality of it. So I tell them, look, you're going to have soreness from taking out that tooth. The implant itself will help, seal up that site, the bone graft, so that you don't have this open exposed wound. If we would have just taken the tooth out and left it, that's what you'd have, and it would be way more sore than it is going to be. But your gums and everything are going to be tender. So I want you to take some Tylenol and ibuprofen. I'm going to give you a pain med just in case. And then, they're always on their post-op antibiotic. And so, but sensitivity wise, absolutely is not increased by drilling past your original apex, not at all. Okay, and I think that answers all the questions that I got tonight. So I thank you guys very much for here. And again, thanks for all the nice compliments. It's been a joy to be able to teach this, and I look forward to teaching more down the road. I love to be able to reach you all, from my home base. In fact, I ran from teaching or coaching football, and that's really what I do. So you'll find that a lot of the work that I do is helping people to continue to get back in the game, to get in the game, to be confident, to have the techniques and the fundamentals to play it right. So if you can ever, if I can ever be of service to you in any way, please let me know. And certainly you can always email me through the Little Implant Co. And know that, keep in mind there's going to be some awesome new learning opportunities that are going to come out that'll allow you to not only get training at your home base, but training with your assistants. So that's something that I've been working very hard on, and I look forward to rolling out for you all in the coming months. So thanks again. Hope you have a great night, and so go enjoy the rest of your evening, and I'll look forward to crossing paths with you in the near future.